Welcome back to another episode of the Pathway Podcast. I'm your host, Nino Nikolovsky, and today we're fortunate enough to have Dr. Jihad Abouali in the studio to discuss all things knee. Dr. Abouali, how's it going today?
It's going very well.
Fantastic. So just before we get started, we just kind of want to know more about you, where you grew up, your medical background a little bit, highlighting your expertise, credentials, a little bit of your specializations as an orthopedic surgeon.
Sure. So it was a journey to get here where I am now as an orthopedic surgeon. I started off at medical school at McMaster University, and then I stayed there for my residency. It was a tough 5 years of grueling orthopedic residency, learning the craft, learning the trade, learning everything there is to know about orthopedics. And then after that, I subspecialized in sports medicine at the University of Toronto. I did an extra 1-year fellowship just to kind of hone on my skills, get a little bit better at arthroscopy, sports medicine surgeries. And so after my year in Toronto training, I stayed on as staff at University of Toronto, where I started my practice. And I've now been in practice for about 12 years.
Amazing. Thanks for providing a little bit of that background. It's definitely been a long journey to get here, but that's why you're at the top of your game as an orthopedic surgeon here. So today we're going to be discussing all things knee, starting with a little bit of the anatomy of the knee, some relevant structures that are involved, how these structures get damaged importantly, and then before getting in the meat of the discussion, which is of course going to be what kind of surgical interventions take place to address these injuries, and then the typical rehabilitation and recovery timelines, looking for patients depending on the injury type and the procedure as well. So just getting right into it, looking at some of the knee anatomy and understanding how the knee anatomy and the structure might relate to some of its function. I just want to help everyone understand the anatomy of the knee joint. So to get us started for today, we know that an articulation is simply two bones that are connected together and forming a joint. So what articulation or articulations does the knee consist of?
So we call the knee a hinge joint. So it basically flexes and extends just the way a hinge would. It's actually a little bit more complex than that. It has a lot of rotational movements as well, very subtle, but they do play an important role in how the knee moves, especially when you're turning or twisting. And there's sort of three main components of the knee joint. There's the medial side, the lateral side, and then the anterior part, what we call the patellofemoral joint. And so that is a separate sort of part of the joint where the kneecap will glide over the femoral bone. So it's a complex joint, but mostly it acts as a hinge joint.
And just some verbiage there, what exactly is a hinge joint? What does that mean functionally?
Well, basically, if you think of your knee, it kind of works in one plane, which is kind of bending and straightening your knee, or flexion and extension, as we call it.
Right.
So like the hinge on a door or something like that.
Right.
It kind of works mostly in that one plane. But like I said, there's some subtleties to it where there is a bit of rotation that's involved when we're doing sort of twisting or turning movements.
Yeah, I'm sure we're going to get into those twisting and turning movements when we're talking about injury later in the podcast for sure. And then looking outside of the articulation itself, what are some notable soft tissue structures that support the stabilization of the knee at rest or during dynamic movements such as during sport?
Right. So the bones create the foundation of the knee, gives you your skeletal support, but they're really supported by the ligaments and the tendons, as well as the muscles that surround the joint.
Right.
So there's two main ligaments on the outside of the knee, the MCL or the medial collateral ligament, and the LCL, which is your lateral collateral ligament. They kind of act as those two supports on each side of the joint. And then you have the tendons in the front, such as your patellar tendon and your quadriceps tendon, and then the tendons in the back, such as your hamstring tendons. And these are the dynamic, attachments from the muscles that allow you to flex and extend your knee.
Right. And kind of considering the anatomy and the function of this joint, you did mention already that it's primarily a hinge joint, but it's also involved in slight, maybe twisting and rotational movements. What makes this joint particularly vulnerable to sports-based injuries? It's a very commonly injured joint. You hear it all the time. Athletes getting injured. They're out for a certain number of weeks with a knee injury. What makes the knee specifically vulnerable to these sports-related injuries?
Well, I think the most important thing is that it's a weight-bearing joint, and it is quite a complex joint. Like I mentioned, there's a lot of structures that go into supporting it. And because there can be a lot of force when we're jumping, running, twisting, a lot of that force does go through your knee, and those ligaments or those tendons can be susceptible to injury because of the constant force, the constant twisting, the constant load that you put on a weight-bearing joint.
Right. And Now, before going into some of those sport-specific injuries that we're going to talk about and looking at some of those soft tissues that might get damaged, do you personally think that understanding the anatomy of the knee, or any joint for that matter, is important for athletes, recreationally active people who just want to maintain an active lifestyle, and patients? How do you view that?
Yeah, I think it's imperative that as an athlete, as a patient, as a surgeon, we have an understanding of how our body functions and moves so that we can protect it and optimize the function, right? So if you're an athlete, you want to optimize the strength, the flexibility to not only be able to perform your sport or your activity, but also to prevent injury. And the same goes for us as surgeons, knowing the specifics of the anatomy, the function, really helps us to be able to provide better care and ultimately better surgeries as well.
Exactly. And just kind of building off what you said earlier in the fact that the knee is a weight-bearing joint. We know that, again, it's in the lower extremity, so it's going to be involved in locomotion, walking, running, twisting. What are some of those soft tissue structures between the knee joint, perhaps, that might get injured?
Yeah, so there are some vital structures within the knee that act as shock absorbers and basically allowing our joints to move very smoothly. And so those two important structures mostly are the meniscus, which are like little cushions inside. There's one on each side of the knee, the medial meniscus and the lateral meniscus. And then your bones are covered by a smooth layer called cartilage, which allows for a nice smooth articulation as the knee bends back and forth.
Right. So what exactly is the meniscus, and why is it important for knee health and function?
So the meniscus, you can think of it like a shock absorber. It's made out of collagen, and it has sort of a rubbery feel to it. So you can imagine a piece of rubber in between your two bones of the knee. There's going to be some compressive forces that it can withstand.
Right.
And it just softens the forces, softens the blow to the knee when there's impact or loading on it. And so it creates a bit of a better articulation, so there's not as much force going through your cartilage and bone to really try and offload that pressure when you're putting some force on it.
I see. So can you explain what happens to the knee joint when someone tears their meniscus? What's exactly going on there?
So when someone tears their meniscus, it's usually a twisting mechanism or a twisting force that basically grinds the bone into the meniscus, and it can create a tear or a rip. And when that happens, there will be some bleeding from the tissue, some joint swelling. And so someone might see a lot of, fluid around their knee, or might get quite puffy after this type of injury.
Right. And say, for example, a patient walks into your office and they're complaining about knee pain. One question is, where do they typically point if they're complaining about their meniscus? And considering all the soft tissue structures we've spoken up until this point, with all the tendons, the MCL, the LCL running around the knee, stabilizing it, how can you pinpoint that it's exactly the meniscus that's causing their pain?
Yeah, so I think it requires a lot of careful attention to see where the patient is describing their pain, because there's lots of structures around the knee that can get injured and therefore that can hurt or cause pain. And so specifically with the meniscus, it's very localized pain. It's one spot that the patient might point to on the medial or lateral side of their knee, meaning the outside of the knee or the inside of their knee. It doesn't tend to radiate down the leg or move to other spots. Patients can often point to their pain with one finger, which we ask them to do. Can you point to your pain with one finger? And if they point along the joint line, which is where the knee bends, that could be indicative of a meniscal tear.
I see. And do you find that it's common for these patients to come in with isolated, or the isolated problem is the meniscus, or do you find that it's usually a more global problem where there might be other structures at play here as well?
It depends on the mechanism of injury or how they tore it.
Right.
There can be traumatic injuries. Commonly, a meniscus is injured in a deep flexion or deeply bent position with some sort of twisting action to it. And so in those cases, it can be an acute tear where it's just the meniscus that's involved. Other times, there can be other structures involved if it's a more forceful or impactful injury, which we'll get into, such as the ligaments within the knee.
Right.
And the other way people can tear their meniscus is what we call degenerative tears. So just wear and tear over time. You have an active job, you've been an athlete your whole life. These things can unfortunately wear down over time, and they can just kind of appear as we age, essentially.
That makes sense. I think we can transition and look kind of directly at isolated meniscus cases. and just potentially some surgical options and interventions that might happen and might be required to address those tears. So when you have clinically established that the meniscus is the cause of your patient's pain, what are some of those subsequent and following conversations you have with them to establish a plan of action and what kind of intervention you'll be proceeding with them?
Well, the first thing we need to confirm the diagnosis of meniscal tear is an MRI.
Right.
And that provides crucial information, specifically the location of the tear, whether it's in the front or the back. And secondly, what zone the meniscus is torn in. So there's different zones of meniscus tears. Within the center part of the meniscus, there's less blood supply or no blood supply, in fact, to that part of the tissue.
Right.
And the further to the periphery or the outside of the meniscus that the tear is, there's more blood supply. And so the zone of the injury is going to determine often what we can do to help treat that meniscus. So if it's within the central part of the ring, often that requires a partial removal of the torn fragment, which is called a meniscectomy. And if it's getting towards the back or the periphery of the meniscus, sometimes we can repair that, preserve the tissue, save the tissue, and that's called a meniscal repair.
I see. So kind of talking about different zones of the meniscus there, looking at with the lack of blood supply versus a blood supply. So what does that lack of blood supply imply? So if there's no blood supply to the middle of the meniscus at those specific zones, why does that necessarily mean that that part has to be removed? Why can it not be repaired?
So essentially, the blood supply to any tissue in our body provides all the nutrients you need to heal tissue, right? And so, for instance, when you cut your skin, you get bleeding to that part of the injury. It creates a scab or a scar, and that gets replaced by new tissue. If you were to tear your meniscus or have an injury where it rips, unfortunately, without blood supply, there's going to be no introduction of growth factors to help that tissue heal. So whether I stitch it together or we try and let the body heal on its own, there's really no regenerative capacity for that to happen without any blood supply going to that tissue.
I see. And kind of before going into the two different types of meniscus interventions being meniscal repair versus a complete meniscectomy or removal of that, as you alluded to, are there any specific risk factors that might place a certain patient based on age, gender, kind of sport that they play, more at risk of tearing that part of the meniscus that has a lack of blood supply versus increased blood supply? Or is it kind of specific to the patient?
I think anyone can really get any type of meniscal tear, depending on just the position you're in or the sport you're playing. I wouldn't say certain athletes are more likely to get certain meniscal tears than others, or older patients get different type of tears. Certainly, as I mentioned before, if people have been pretty hard on their knees over the year, they get a degenerative type of meniscal tear or a complex tear. But unfortunately, whether you're 16 or you're 60, you can get a tear within the middle of the meniscus, the periphery, or the central aspect. So it really depends on the force and the angle that you caused the injury.
I see. So we kind of established up until this point that you've identified the meniscus as the cause of the pain through an MRI. So with imaging techniques, and clinically, I assume they're also pointing to that midline of the joint, as you mentioned. So now, in terms of the next steps, looking at some interventions, could you walk us through kind of a step-by-step of what's going on versus a meniscal repair surgery compared to a meniscectomy, and kind of how they compare and contrast with each other?
Sure. So I'll start with a meniscectomy or partial meniscectomy, which means removing part of the meniscus, because often we don't remove the entire meniscus. We're really trying to preserve as much of that tissue as possible.
Right. So
the goal of the meniscectomy is to get rid or trim off the part that's causing the pain or causing the irritation.
Right.
And we call those pieces the unstable fragments. Okay. So when there's a piece of meniscus that might be moving around inside the knee because it's torn, that can cause pain. It can cause catching within the knee or locking symptoms. And so that fragment needs to essentially get resected or be removed. So now you have a smooth meniscus again, and your knee can function and glide easily without anything kind of interfering or blocking its mobility.
Right. And how does that kind of compare? So you mentioned that's a partial meniscectomy. How does that kind of compare to what a repair would consist of?
So a repair is basically you're not removing any of the tissue, but you're trying to stitch it back together. And of course, as I mentioned, the meniscus has an important function of the knee of acting as a shock absorber. So if we can stitch it back together, then we're preserving that function. And this can only be done if there's a tear in the area where there's good blood supply, as mentioned.
Perfect. So before we go into what's actually happening during the intervention and what a repair versus a meniscectomy looks like in the actual operating theater, what's a kind of typical person that walks in who has this kind of meniscal repair? Who's at risk of tearing their meniscus? And is this dependent on the kind of sport they play, the kind of movements that they're doing? If you can kind of touch on that.
So you can unfortunately tear your meniscus in lots of different ways. As I mentioned, often patients will be in a deep flexion position or some sort of twisting mechanism. So that can be through sport. It can be through your job. If you work on your knees a lot, like you're a plumber, sometimes we see it where people are in that deeply bent position, and as they go to stand, they feel or hear a pop. So it can happen from sport, occupation. Some people just have a simple trip and fall, and you can get a meniscus tear as well.
I see. So it's not really a specific risk factor. Anyone's at risk, but depends on if you're involved in that deep flexion positions or rotation, if you're more inclined for that.
Yeah, correct. The more often you're in those positions or making those types of movements, unfortunately, the more at risk you are of getting a tear.
Makes sense. So if a patient walks into your office and they have concerns that this meniscal repair is going to be a massive surgery resulting in a year of recovery post-operation, how can you kind of improve their confidence in the surgery that the recovery timeline can actually be more reasonable for them?
Well, fortunately, we can do this all through minimally invasive techniques. So that involves using a camera to make a tiny incision around the knee and insert the camera through a keyhole incision. So it's usually 2, maybe 3 small 2mm incisions. The camera is inserted through one of those portholes, and the other portals are used to introduce the instruments to go in and repair the meniscus. So everything is done within the joint through the camera. There's no large incisions. Often what that will entail is once we're inside having a look, we find the tear, we put it back in its place because often there's some tissue that's out of place. So we reduce the tissue, get it back into its original shape, and then we need to go in and actually stitch it back together. And that's done through all minimally invasive, all inside techniques where we place some instruments inside to stitch it with some specialized instruments without having to make any large incisions around the knee.
I see. So what does that stitching process consist of? And is this going to vary between people depending on the type of injury or the type of tear that you see while you're inside the knee arthroscopically?
So there's lots of different types of meniscal tears, lots of flavors, if you will. So it's not a cookie or cutter approach where everyone gets the same type of repair. Depending on the location, the configuration, the shape, it may require certain types of stitches, certain anchors or implants to be used. But fortunately, like I said, that's all done within those keyhole incisions through the camera. And so we can go ahead and repair whatever needs to be repaired, all staying within inside the joint and, keeping it minimally invasive.
Fantastic. And do you find that it's usually the medial meniscus that's a problem or the lateral? And is there a difference between the two there and how they function biomechanically?
Most commonly, we see medial meniscus tears for a couple of reasons. One, with wear and tear of the joint, as people get a little bit older or have had a lot of wear and tear in their knee over time, the medial meniscus tends to be injured first. And then with sports injuries, we commonly see in repetitive sports injuries, people can often get medial meniscal tears as well. Mm-hmm. What was the second part of your question?
And how does this compare with the lateral if you see kind of more medial-based tears or lateral-based tears, and if there are differences functionally or biomechanically between the medial side and the lateral?
Yeah, that's a great question. So when we look at the shapes of the bones, the medial side of your knee acts a little bit like a ball and socket. Now, I called it a hinge joint.
Right.
But if you look at the shape of the medial part of your femur, called the medial condyle, and the medial part of your shin bone, the tibia, they actually look like a ball and socket joint.
Right.
Whereas on the lateral side, they're flatter, the bones, so they actually kind of glide back and forth as opposed to rotating. And so because of that, the lateral side of your knee really relies on that meniscus to make it shaped more like a cup. So we see that when people have a lateral meniscus tear, they don't get the same, nice articulation that you should have, and it can wear down that part of the joint better. It can wear down that part of the joint faster.
Right.
Whereas on the medial side, yes, it can still cause you pain, but it doesn't lead to as much wear and tear in your cartilage over time.
Right. And before kind of going into the meniscectomy or the removal, what kind of outcomes can patients expect with a repair, be it medial or lateral meniscus?
Well, a lot of that depends on the type of tear that I've repaired, but generally speaking, success rates are quite high after meniscal repair surgery if it's done with the right indications.
Right.
And so it takes some time to get recovered from this and rebuild up your strength and mobility. But if we save that tissue, people often have better function now that their meniscus is repaired. They have less pain. And most of all, they've been able to preserve that tissue and try and prevent arthritis from occurring in the future.
Right. And in the case of athletes who are coming in with a meniscal repair and they've done the necessary physio to re-strengthen the muscles and tendons surrounding the joint, can they expect to be pain-free and go back to sport?
That is certainly the expectation, that people get back to a high level of play, high level of function, and they should be pain-free. As I mentioned, it takes some time to get there. Right. But we go in with the intent of restoring their anatomy so that their function is restored as well and they're pain-free.
And what's the kind of timeline of that following surgery? I'm sure it's going to vary between individuals and depending on the extent of the tear and the damage that was incurred. But what's the kind of timeline that you can expect post-operatively to fully rehabilitate and regain that necessary strength and feel pain-free?
I would say the average timeline to make a full return to sport or your physical job would be about 5 or 6 months. We work in a stepwise approach to ensure that we're first getting the range of motion back, followed by some strengthening. Right. And then we work on more dynamic parts of the recovery, agility work, speed, and coordination.
Right. So I think that's, unless you have something left to add on to meniscal repairs that you feel we haven't touched on, we can move on to meniscectomy. We just covered a partial repair of the meniscus. So I think we can move on to a meniscectomy, which is more of the removal of the meniscus if it's not able to be repaired. So how does this kind of compare and contrast to the repair that we just spoke about?
So the cases where we're doing a partial removal of the meniscus or a meniscectomy are in instances where the meniscus is not repairable because it's not in a vascular zone. There's no blood supply to that tissue.
Right.
And the main purpose we would be doing the partial removal is to get rid of any irritating fragments that might be causing pain, catching, or locking of the knee. So by reshaping the meniscus and removing a small fragment that's irritating the joint, it will allow for better mobility of the knee and hopefully less pain as well.
So in terms of intraoperatively, when you're in the operative room and you've established that the partial meniscectomy is the operation for this patient, how does it kind of look like in the operating theater, and how does that differ from what's going on in a repair while you're inside the knee? And is this also minimally invasive?
Yeah, so the setup is actually quite similar to meniscal repair, where it's done with minimally invasive techniques, 2 tiny keyhole incisions on each side of the knee.
Right.
One for the camera to evaluate the meniscus tear, and the other little incision for the instruments to go in to trim off a piece of meniscus. It's usually a much faster operation because there's just one fragment to remove compared to a meniscal repair.
I see. And when a patient comes in your office and based on MRI imaging, you can tell that a partial meniscectomy is going to be required, do they have any concerns, or what are some typical concerns that patients have when you tell them you're going to have to remove some tissue from their knee?
Yeah, I think everyone says the same thing when I propose that surgery is, well, don't I need that piece of tissue? And yes, you do need that piece of tissue, and it is an important structure. But unfortunately, we're not always able to repair every single tear, and that's not just that doesn't just apply to the knee. That applies to any kind of orthopedic condition. So we save tissue, we repair tissue when we can, but we know not every piece of tissue or every meniscal tear can be repaired. And so in those cases, we're trying to improve patients' function, improve their quality of life by offering them a partial resection of the meniscus.
And in the short term, where you're now taking out the problem that was inside the knee, being that part of the meniscus that might be catching on the midline, causing that pain. I think, is there ever any concern on a longer term, now you're removing the weight-bearing portion or what's helping with load-bearing during locomotion and walking? Is there any ever concern about arthritis that might occur now that you're more bone-to-bone potentially?
Yeah, so with a torn meniscus, unfortunately, you've lost that function of the shock absorber in the area where it's torn. So there's already going to be increased contact forces going through the joint in that area.
Right.
And as I mentioned, it is always my intention to try and repair that tissue, to try and restore that function of the shock absorber. But in cases where we do have to remove it, there is going to be increased pressure going through the cartilage, which is a risk factor to get arthritis in the future.
I see. And you mentioned in the repair side of things that outcomes are generally successful and there's about 5 to 6 month timeline for recovery. How does that kind of contrast with meniscectomy and what kind of outcomes you found for those patients?
So the good part about a meniscectomy is that patients do recover quite a lot faster than a meniscal repair because there's no internal sutures or stitches placed into the knee.
Right.
There's nothing you're really worried about protecting. So patients can weight bear right away, meaning they can put their full body weight through the knee. They can bend the knee as much as they want, even the same day or the next day after surgery. So the recovery timelines are about 4 to 6 weeks after a partial meniscectomy compared to 5 or 6 months after a repair.
Perfect. And for patients who might be concerned and they've been diagnosed with some meniscal damage, are there any possible risks or complications patients should be aware of? And how can you increase confidence in their decision to maybe proceed with surgery or non-surgical interventions?
Yeah, that's a great question. So every surgery has some risks. And fortunately with arthroscopy or keyhole surgery, those risks are quite low because the incisions are small, the operations are short typically, and we find that the complication risks or complication rates are less than 1%. So there's still some risks of infection, bleeding, and blood clots, but they're really quite rare in minimally invasive surgery.
Perfect. And after surgery, how can patients best support their own recovery, working with a physiotherapist or yourself to ensure successful outcomes? What should post-op physiotherapy programs be targeting specifically to help support this repaired or removed meniscus?
So we have early, mid-range, or midterm and later term goals as we walk people through the rehabilitation process. It's imperative to have a great team working with the patient. Right. Often that includes, connecting with a physiotherapist or a sports therapist to help with their recovery. So early on, we're trying to get the inflammation and swelling down, lots of icing, lots of elevation of the limb, getting the circulation to get restored. And then in your midterm, you're trying to restore your range of motion back as soon as possible to, prevent any stiffness after the operation.
Right.
And then towards the end, we're working on strength, conditioning, agility work, and basically getting them ready for a return to sport.
And that makes sense where you have those that phased approach. You ever find with athletes that it's ever a problem where they say they want to return back to sport within 2 weeks? They just got out of the operating room and they say, I'm feeling a little bit better. I want to go back to the field or the rink or whatever they might be playing. What do you have to say to those athletes who want to come back as soon as possible?
Yeah, I think in the meniscal repair setting, that is a common, challenge for these patients is to really slow them down because they're high energy patients. They're used to, working out consistently and putting everything they have into their rehab. But sometimes, rest is best, if you will, and you really got to let that tissue heal, get the swelling down before we start putting too much stress on it when it's not ready and it hasn't healed yet. So it's, me coaching the patient, reassuring them that they're going to get there. We have a timeline that we've talked about in advance. We got to stick to that timeline for a reason. It's based on their biological healing, and you can't always speed that up, right? So in these cases, time is their best friend.
Definitely. I think focusing on recovery, they know what it feels like to have a torn meniscus and playing through that. They've done the hard part now. They've gone through the surgery and then optimizing that post-op rehabilitation. Welcome back to another episode of the Pathway Podcast. I'm your host, Nino Nikolovsky, and today we're fortunate enough to have Dr. Jihad Abouali back in the building to discuss all things ACL, Dr. Abouali, how's it going?
It's going very, very well. Thank you.
Perfect. Before we hop into all things ACL, the most famous ligament in the body, just wanted to give you a chance to provide some background about yourself and your kind of upbringing and into medicine.
Yeah, sure. So I practice as an orthopedic sports surgeon. There's lots of different areas within orthopedics, but my specialty is taking care of athletes, young and old, who have sport-related injuries. And, I've had a lot of experience taking care of some professional teams like the Toronto FC, the Toronto Argonauts, the Scarborough Shooting Stars. So you see, sort of the top tier athletes, but I see recreational athletes, masters athletes, kind of all comers from all walks of life. So I've really, honed my interest and passion into helping people with soft tissue sports injuries.
Amazing. Thanks for providing a little bit of insight into who you are and your background into medicine. Today, we're going to have a great discussion, all things ACL, from reconstructions to repairs to what the ACL actually is, the infamous ligament. So before we actually go into some mechanisms of injury with the anterior cruciate ligament, or more infamously known as the ACL, could you first provide an overview of what the ACL is and why it's so vital to knee stability during dynamic movements in sport?
Sure, absolutely. So the ACL, or the anterior cruciate ligament, is one of the main stabilizing ligaments of the knee. It connects your femur to your tibia, and it prevents the shin bone or the tibia from coming too far forward or over-rotating when you're doing dynamic movements, such as in sporting activities. So it really does give the knee a lot of stability to withhold and withstand a lot of force in those movements.
I see. And again, I mentioned the ACL is probably the most infamous ligament in the human body. You always see it in the world of professional sports, athletes out for a year. So why do you think it's such a commonly injured ligament? And what are some potential mechanisms of injury when you're looking at the ACL?
Well, we see the ACL injured a lot in pivoting sports. And it's actually a non-contact injury. So it happens when someone's changing direction quite quickly, often, in a sudden movement or unpredictable movement in a sport. And because it's a pivoting injury, because it's a pivoting injury, sports that involve a lot of twisting or cutting, such as soccer and basketball, rugby, it can put the patients at risk of getting this injury.
So it's interesting you mentioned that it's a non-contact injury. Is it, for example, if you're looking at rugby or football, which is a high contact sport, if someone were to get tackled around the knee area, would it be the contact that would tear the ACL, or would it be on their landing if they missed their landing?
So you're right. It is actually on the landing. So the foot is planted and the body keeps rotating, but the foot sort of does not move with it. And that's what snaps your ACL. So we can see it in contact injuries. However, it's not the contact to the knee or contact to the body. It's the fact that the body or the knee over-rotates on that planted foot.
Interesting. So it's kind of like the ligament goes into tension and kind of snaps, as opposed to you get hit on the knee and it's the actual blunt force trauma that's causing that
Correct.
snapping?
Yeah, correct. You can injure other ligaments like the MCL or the LCL from direct blow or direct contact. But it's with an ACL, it's usually just the body moving too quickly or with too much force on the planted foot. And often, like I mentioned, or more often than not, it's from a non-contact injury.
And going back to that example of that football player who just got hit on the side of the knee, landed poorly, he's on the floor in pain. Without seeing an orthopedic surgeon, how can that athlete tell that they've torn their ACL?
Yeah, there's a lot of common telltale signs that an athlete can tell that there may be some damage to their ACL and should probably go see a doctor. But the number one thing I would say is it was a non-contact injury, or perhaps they got, hit in the air, and when they landed, that's when they felt the pain. Number two is they can't get back into the game. There was just too much pain or too much swelling that prevented them from going back to that same game. Number three is swelling, right? So this knee can swell quite a lot later in the day or the next day. And that's not a great sign. That means there has been an injury within the knee joint. And so I think if you kind of have those things, non-contact injury, couldn't return to play, the knee is swollen, that is unfortunately very likely to be an ACL tear, or at least warrants, the athlete seeing a physician or, a sports therapist.
For sure. And I think that's also why athlete awareness and education about this is so important. Those are simple telltale signs that you've torn your ACL, because often they'll look at that and their coach will say, just put some free spray on it, get back out there, keep playing. But when the ACL is injured, why doesn't it typically heal on its own?
Well, the ACL is under a lot of tension naturally with natural movements of the knee. And so when it tears, it often tears right in the middle of the ligament or from the femur, the thigh bone, and it sort of retracts backwards, right? And it unfortunately doesn't have any way to reattach and regrow back. And within the knee, there's naturally some fluid, what we call synovial fluid, and that tends to wash away any clot that can form to reattach the ACL.
Right.
And so because there's no clot that can form and mature and turn into new tissue, it never really has that healing potential to regrow or reattach.
So it's just because the fact that the ACL is inside of the knee joint rather than outside in terms of intrasynovial as opposed to extrasynovial.
Yeah, correct. The ligaments on the outside of the knee, there's very good blood supply, but there's no synovium that will wash away the blood.
I see.
Whereas within your knee, the ACL is bathed in this synovial fluid. And unfortunately, that fluid keeps washing away the blood clot and never allows it a chance to really mature and reform a new ligament.
Right. And you mentioned that this is in the cases of a complete tear where it snaps and then retracts. Is this going to differ if it's partially torn?
It may. We do think that partial ACL tears can heal. It's very individual. Not always they're not always going to heal, but sometimes they can. And so it requires, a lot of patience to see if that partial tear will heal, because it may never heal, but it could take up to a year to do so.
And just to provide some context of this injury, what are some of the most common sports? You did mention pivoting injuries as the primary mechanism, but what are some of the most common sports and athletes that walk into your office with an ACL tear?
So the top 3 sports that I see are soccer, basketball, and skiing. Soccer and basketball, a lot of jumping, twisting, cutting, changing directions. So we see that all the time in that sport. And with skiing, because it's such a high velocity sport, and patients, when they have a bad fall, their boot doesn't often come out of the binding. So there's a lot of twisting force going through the knee as well. That's probably the third most common mechanism that I see, or the third most common sport.
Perfect. And just a question I'm personally curious about. You mentioned soccer, and I'm sure footballs can be thrown in there as well. Have you found a difference in injury rates between players who play on grass versus turf? Is that a consideration?
It can be a consideration. I think with turf, there's less give in the surface. And sometimes your cleats can get stuck more in the turf. And so we do see a slightly higher incidence of ACL tears in soccer players playing on turf compared to grass.
I see. So I think we can definitely transition into kind of a surgical intervention for the ACL. And say a patient has walked into your office, they've exhausted all of their non-surgical options. They've said they've gone to physio for X amount of time and they're not seeing any improvement. What are some of the discussions that you have with them and potentially some of the imaging that's requested to identify that this is an ACL tear and this is a surgical intervention that has to be done?
Right. So for all these patients who we suspect the ACL may be torn, we're going to want to order an MRI to confirm that diagnosis, that the ACL is in fact torn, but there's potentially other structures such as the meniscus or cartilage that can have associated injuries with this.
Right.
So it's very important we get the full comprehensive diagnosis before we make a surgical plan. And then when we're talking specifically about the ACL, the reason we would want to reconstruct or offer the patient a reconstruction is because they feel instability in their daily lives or with their sporting activities. And by providing them with an ACL reconstruction or a new ACL, you can restore that function, give them confidence to return back to their sport or other activities where they feel instability.
Right. And before we proceed with reconstruction, just to provide some context, what is the difference between an ACL repair and an ACL reconstruction? Just going into some of that terminology differences there.
So a repair, as it may sound, is where you're actually restoring the original ligament or stitching it back together. So you don't need to replace it. You're trying to preserve the original tissue. That's an ACL repair. With a reconstruction, the term reconstruction means to kind of recreate a new ligament.
Right.
And that means taking a tendon from another part of the knee or sometimes from a donor to replace the ACL and reconstruct it.
Right. And I think you just alluded to the fact that you're recreating a new ACL. And I think the terminology there is an ACL graft that you'll be choosing. So could you briefly explain what a graft is and why it's necessary in ACL reconstruction surgery?
Yeah, so for an ACL reconstruction, those are cases where we really don't think whatever ACL tissue is remaining in the knee is going to be good enough to repair.
Right.
And so rather than taking that chance of stitching it back together, we're going to provide a new tendon to recreate that ACL, something that's quite robust and can heal reliably within the knee. And so we tend to do that procedure most commonly when we see full ACL tears.
Right. And what are the main types of grafts commonly used to reconstruct the ACL?
So it can be separated into two categories, something from the patient's own knee, which we call autograft, or donor tissue, which is called allograft. When we talk about autograft or getting a different tendon from the patient's own knee, the most common ones are the patellar tendon, the hamstring tendon, and the quadriceps tendon.
Right. And what are some differences among those common autografts, looking at the hamstring tendon, the patellar tendon, and the quad tendon, in terms of how you're making the decision on what to use and if that's going to differ between people and athletes?
So I would first say that all three tendons do offer very reliable options for, or a reliable graft for the patients. Depending on the type of sport they play, they may opt to have a different type of graft that will help them perform better or reduce the risk of repeat injury. So for a long time, the gold standard has been the patellar tendon, and we still employ that a lot in patients who are younger or play a lot of pivoting sports like soccer, basketball, football. The hamstring is also a very popular option, very commonly used for ACL reconstructions because you get quite a lot of good tensile strength with that tendon. And it perhaps is a less painful procedure than using the patellar tendon. And finally, the quadriceps tendon is something that's being reevaluated and coming back into fashion a little bit because it offers a reliably good tendon, and you can predictably get a good size of graft.
Right. And when you say it has a similar tensile strength or a strong tensile strength, is this the reference point of the original ACL where we've been able to establish the tensile strength of an original ACL in a human being? And how does that kind of differ from the tensile strength of a graft?
Yeah, correct. So we look at load to failure, or how much force needs to go through the tissue before it can tear or fail.
Right.
And most graft options have a higher load to failure than the original ACL.
Wow.
The hamstring has the highest. That doesn't necessarily mean it's going to be the strongest or fail less, but when we look at sort of biomechanical studies, we know that the hamstring is actually the strongest of the three tendons.
Interesting. And I think we can just hop right into what happens during an ACL reconstruction surgery. You've established that it's a full tear that's going to require reconstruction. A repair is not sufficient enough to result in the best outcomes. So what is going on during an ACL reconstruction surgery as the patient's walking into the operating theater?
So after we've brought the patient into the room and they're off to sleep, we'll start with the first part of the operation, which is to take the graft or harvest the graft from the patient's knee, whether that's the patellar tendon or the hamstring tendon. And we're going to prepare that tendon so it's ready to be implanted into the knee. But before we get to that stage, we perform the arthroscopic part of the procedure, which is the keyhole minimally invasive procedure. It's done through two tiny incisions around the knee to put the camera inside and evaluate the full extent of the damage. Often that may include repairing the meniscus or cartilage and removing the old ACL scarred tissue so it's nice and clean and ready for the graft. Once that's complete, we need to be able to insert the graft into the knee, and that requires placing a tunnel or essentially a hole in the femur, the thigh bone, and the same thing goes on the shin bone, the tibia. So we'll have two holes that the graft can pass through to be affixed to each side of the knee. And then we need to keep the graft there by placing some implants in. So if it's for a patellar tendon graft, we often use screws. And if it's for a hamstring graft, we often use buttons.
Right. And I just wanted to go back to some of that terminology that was used before in terms of harvesting a graft. So do patients ever come in with concern that you're taking tissue from another part of their body and how that would kind of heal? And how do you kind of increase their confidence that that's completely normal and this is required for this ACL reconstruction?
I think everyone has that concern about taking something from their own knee to replace something else. But really, that's the gold standard of care because nothing heals inside your own knee like your own tissue. We find it heals most reliably. There's no chance of, we find that it heals most reliably. There's no rejection of the graft because it's your own tissue. Right. So it really is the gold standard to use your own tissue, especially in younger patients, because we find that the re-tear rates are lower when we use their own tissue compared to using donated tissue.
So in terms of using an autograft as opposed to an allograft?
Correct. Yes, exactly. The re-tear rates are lower when you use autograft compared to allograft, especially in the younger age demographic.
I see. And in terms of the post-operative period with the ACL reconstruction, what does kind of the physiotherapy look like and the rehabilitation and the timeline of recovery as well for ACL reconstruction patients?
So I always tell patients the surgery is the easy part, to be honest, and the rehab is the hard part, right? So they're going to be on crutches typically for 2 to 6 weeks. They're still allowed to get engaged in physiotherapy right away to get the knee moving, basically relearning how to walk and then getting the range of motion back in their knee. So that takes a period of 2 to 4 weeks. And then we're going to get the muscles activated, start to build up the strength slowly. Once we find there's sufficient strength in the knee, we'll start to work on some more dynamic activities, jumping and running. And to the latter end of their recovery, we start to work on agility, cutting, pivoting, and getting them into game shape, basically.
It sounds pretty similar to the recovery of meniscal repairs and meniscectomies, where it's just that kind of progressive overload idea. Where you're just trying to reduce that inflammation immediately post and then progress to as close as sport specific as you can later into the recovery.
Yeah, it's similar timelines. I think with an ACL, because it's a larger operation than the meniscus, it does take a little bit longer to make a full recovery back to sport. Typically, we're counseling patients that it can take around 9 months to get back to full steam.
Right. And how do patients feel when they do get back to sport? Do you find there's feedback where they might be hesitant on the field, or are they fully back to their original style of play and how they like to play?
Well, we only let patients get back to sports when they've cleared a lot of check boxes and reached all their goals. And so that includes having a fully healed ACL, full strength or very close to full strength compared to their non-surgical leg. And, it's a graduated return with practices and then limiting your minutes in games before you're back to 100% full play. But a big part of recovery is also the sports psychology. A lot of patients do have fear about re-injury, fear of having to go through this surgery again. So we do have to reassure patients when they are ready that they can do it.
And on that note, how are the recurrence rates in terms of ACL reconstructions? The patient has abided by the entire physiotherapy program, say 9 to 12 months. They've strengthened the quads and the hamstrings around the knee to support. How is the recurrence rate in those cases?
So there's a lot of factors that go into the recurrence rate or the chance of the ACL re-tearing. Probably the most important thing is how old they are and the type of sport that they play.
Right. So
with younger patients who play pivoting sports like soccer and basketball, the rates can be a little bit higher of a repeat injury, can range from about 8% to 15%. That will also change with the type of graft you've selected. With patellar tendon, that does offer the lowest chance of a re-tear, where some other grafts like the hamstring or allografts, donor tissue, can have higher risks.
And yeah, exactly. So before I wanted to hop into ACL repairs, we touched a lot on autografts, looking at the quad, patellar, and hamstring tendons. Can you explain what an allograft is and where it's sourced, and if you would ever consider this in your own practice?
So allografts are donor tissue that comes from a deceased patient who's, very graciously offered their tissue to be used for medical procedures. And so typically we will take an Achilles allograft or a hamstring allograft from the donor tissue. And we tend to use these grafts in very specific situations. Number one would be the older athlete. And the reason why is because taking some of their own tissue might lead to a more challenging recovery.
Right.
Because it can weaken their muscles. So if we can avoid taking something from their own knee and using some donor tissue, it might allow for a bit of a more predictable and easier recovery for the older patient. The second instance where I use an allograft is in a revision setting. So someone has unfortunately torn their ACL a second time, rarely a third time. We start to run out of things to use from their own knee.
Right.
Or it's been too much trauma to that one knee. So we start to look into the other option, which is the allograft.
I see. And are there any misconceptions or common misunderstandings about graft types that you encounter with patients in your practice?
I would say the most common misconception is that the allograft would be better, because patients do sometimes have the feeling that, why don't I just use some other person's tissue or some other tissue that's not my own, so I don't lose my own strength.
Right.
But it's actually never been shown that patients who use allograft, especially the younger patients, do better. In fact, we find the opposite. We find that their risk of failure is higher because, like I mentioned earlier, nothing heals as good in your own knee as your own tissue. So when you use someone else's tissue, there's a much higher chance that it doesn't really incorporate or heal well into your own knee.
I see. That makes perfect sense. So I think we can definitely transition into ACL repair if you feel like everything's been covered for ACL reconstruction at this point. Yeah. I think we were able to cover what kind of patient walks in, that twisting motion as the main mechanism of injury, and the indications for that.
So I rely on the MRI a lot to help me guide my decision making. So if the ACL has a partial tear, or it's torn near the proximal aspect, the top part of the ACL where it comes off the femur.
Right.
In select cases, you can actually stitch that ACL back together and reattach it to the femur. So a lot of that will depend on if it's a complete tear and where exactly along the length of the ACL it's torn. And so if it's one of those proximal tears, perhaps there's some of it still remaining that's attached, that might provide the opportunity to actually restore the original tissue and repair it.
That makes sense. So could you now walk us through what happens during a typical ACL repair procedure and how this differs from an ACL reconstruction?
Sure. So in contrast to an ACL reconstruction, where we start by taking a graft from the patient's knee, we don't need to do that in this situation. So we proceed directly to the arthroscopy, the camera surgery,
right,
and we have a look and we fully evaluate the ACL tear. Now it's dynamic. We can see it up close. We can probe the tissue or move it around, see how much of it's torn, see where exactly it's torn, and make a determination if it's repairable or not.
I see. So if you have made that determination that it is repairable, what are kind of the next steps intraoperatively looking to repair that tissue now?
So the first thing we want to do is mobilize the ACL tissue. So if there's some scar around it, we want to clean that up to get rid of anything that's really not helping or getting in the way. And then the second thing is to stitch the ACL, placing some, strong sutures through it so we can basically bring it right back up to the femoral bone where it's detached from.
I see. And
Can you just redo that one with
a little bit.
The Arthrex video has like a really good animation.
Yeah.
He's like using a small passing device.
Yeah. A little bit more detail on that.
High grade suture through the ACL.
Right.
That's then passed through an anchor which is attached to the
Perfect. Yeah.
side.
Yeah. I went a little bit faster that. Okay.
Yeah. Because the ACL repair is very enticing, right?
Yeah.
It's a sick marketing option.
Yeah.
If it's the right patient, right?
For sure. Okay. You want to ask me that question again?
yeah, so my question was
It's
just,
really good for that.
Once you've made that determination,
Yeah.
how do you do it?
so once you've now made that determination that an ACL repair should be done, what are the next steps involved in the surgery?
So the first thing we do is get rid of any scar tissue that may be interfering with the healing of the ACL and sort of just getting in the way.
Right.
The second thing we want to do is stitch the ACL. So we can use some very fine instruments to go in and put a high strength suture through the entire ACL. And those stitches need to be implanted into the bone through what's called a suture anchor. So with the stitches and the anchor, it basically brings that ACL right back up to the femoral bone where it tore off of. And then we need to sort of reinforce that repair. So we use what's called a brace suture, where we place a strong suture right on top of the ACL to anchor it from the femur into the tibia. So it has sort of a seat belt, like a check rein, so that there's added reinforcement around the ACL.
See, fascinating. And in terms of how long patients can expect to be under and in the procedure itself, how does this differ between ACL reconstruction and repair? How long do these procedures take?
It's actually a bit faster than an ACL reconstruction to do an ACL repair because you don't have to take the graft at the beginning of the case.
Right.
And it's only done minimally invasive through the scope. So it's about a 1 hour surgery.
I did want to mention, because you said that you go in arthroscopically to kind of assess the knee joint. Say you go in arthroscopically and you find other problems there, maybe the meniscus, maybe some other ligaments involved. How do you then kind of go about the rest of the procedure, and are those issues addressed as well?
Yeah, so we're there already for surgery, so we don't want to bring the patient back a second time to do another procedure. So it's a one-stop shop. We're going to do everything at the same time. So I counsel patients that if the MRI didn't pick up an injury that we find during the arthroscopy, we're prepared to fix everything all at the same time. So whether that's a cartilage injury or a meniscal injury, we're there, the patient's already asleep. We want to do everything so they don't have to come back a second time.
Right. And just comparing ACL reconstructions with ACL repairs, it seems that based on your description, ACL reconstructions are more invasive. You're taking an autograft as opposed to repair, where you're just using suture anchors to repair it. How do outcomes differ between ACL reconstruction and ACL repairs in terms of functional ability post-surgery, pain, activities of daily living, return to sport?
We find that with ACL repairs, it's an accelerated timeline to recover because you didn't take a graft from the patient. You're not drilling these large holes in the bone. You're really only putting these small suture anchors.
Right.
Patients have much less pain, much less swelling, much less use of post-operative pain medications. So everything is accelerated right from the get-go. They get their range of motion back faster, the joint is less swollen, and they can start to fire their muscles much sooner than an ACL reconstruction. So typically I'm telling someone with an ACL repair, their timeline to return to play at a very high level could be around 6 months, whereas as discussed before, for an ACL reconstruction, it's 9 months or longer.
Amazing. So I think we've covered a lot of important things today in terms of comparing what the ACL actually is, this infamous ligament that's been injured in many athletes, put a lot of athletes out of their career, and some surgical interventions that can be in place there. I also wanted to ask one more question regarding ACL reconstructions, which is the more intense procedure. So we covered the fact that there might be some other issues going on along with the ACL. And I think commonly, based on my understanding, it can be the ACL, meniscus, and MCL. That's a common trifecta of injuries.
Right.
So how is that kind of addressed, where in more serious cases, there's multiple ligaments and soft tissue structures to address?
So when you have this unhappy triad of injuries, there's a sequence to how we go ahead and repair them or let them heal on their own. So often if there's an MCL injury that's associated with an ACL injury, we'll let the MCL heal first because it does have good regenerative capacity where it can heal on its own. So we let that run its course 6 to 12 weeks, depending on the severity of the MCL injury.
Right.
But soon after that, once the patient has restored their range of motion, they have some reasonable strength in their leg, we do want to get to the ACL injury sooner rather than later for a couple of reasons. One, the patient doesn't want to be out for a prolonged period of time away from sports. So we want to offer them the opportunity to return to, their passion as soon as possible. Number two, if there's an associated meniscal tear, we do find that the sooner we can repair those, the higher chance or the higher likelihood it's going to heal. And so we don't want that to have undue stress or perhaps get worse if we delay treatment.
Right. So kind of addressing those earlier is better as the general rule of thumb.
Absolutely, yeah.
Right. And what advice would you offer to someone who might be feeling overwhelmed about going through with ACL reconstruction or ACL repair surgery?
I would say talk to a professional. I see a lot of patients with this injury. I know it can feel devastating, can feel overwhelming, but I see it all the time, and I can answer their questions, or their orthopedic surgeon can answer their questions, just to reassure them that, listen, yes, this is an injury that's taken you out of the game, but there's a path forward to try and get you back, right? And we see it all the time. We know the results can be excellent. You just need a good team behind you. So talk to someone who's been through this. Talk to your physio, talk to your sports doctor, talk to your orthopedic surgeon.
Amazing. And before we conclude today, that was all about ACL. I just wanted to leave the floor open for you. If there's anything that you wanted to cover regarding the ACL, regarding people's mentality towards surgery, or maybe rehabilitation outcomes, or how people might be feeling post-operatively.
I think, when everyone tears their ACL, like we've discussed, it can feel overwhelming, and patients aren't sure if they're going to be able to get back to doing what they love to do. And I would just impress upon patients that if you have a good team behind you, you can get back to doing your high-level sports, your high-level activities, or just enjoying life with your kids, your grandkids, whatever it may be. You just need to be properly educated on this, get proper counseling, and make sure you have the right tools in your toolbox to make an informed decision.
Perfect. And I think on that note, I'd just like to say, Dr. Abouali, thank you for your time. This was very informative and insightful, covering all things knee, meniscus, and ACL. So just wanted to thank you for your time today.
Thanks, Nino, for having me.
Appreciate it.